Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. This is a talk to continue on tooth movement, and this time we're going to talk about mechanics and forces. The same reference, just to remind you, chapter 8 from Prophet, 6th edition, and chapter 5 from Simon Littlewood and Laura Mitchell, 2nd edition. So we're going to start by giving you some definitions and concepts related to the mechanical basis of orthodontic tooth movement. It's important to understand the different types of tooth movement, the force, magnitude, duration, and decay, and how drugs can affect the response to forces and so on, their effect on tooth movement, and the different attempts that were made to accelerate tooth movement. So just to remind you, when we talked about the healthy periodontium and its effect on the normal physiologic function that is related to eruption, over-eruption, migration, and active stabilization of teeth. The cellular response to the normal heavy masticatory forces, and the response to a more sustained pressure that is related to two scenarios, the light pressure scenario and the heavy pressure scenario. So all this was covered in our first talk. Also to remind you with this diagram that gives you the relationship between the number of days passed after you apply the force and the amount of tooth movement. When you apply light forces, that should produce the frontal resorption, the direct resorption, and that's presented with this red line here, and then the dashed black line that represent the effect of heavy force. Now, when we say force, we mean it's the amount of load that is applied on an object, okay, in a certain magnitude, in a certain direction, for a certain duration. And also you need to know what we mean by center of resistance. So for any object, the center of resistance is the point through which, if you apply any force, it should produce bodily movement, translational movement. And the center of resistance is exactly the same as the center of mass, only if we're talking about a freely floating object, which is not the case at all when we're talking about teeth, because teeth are embedded in the socket, in the alveolar bone, surrounded by the periodontal ligament. So the center of resistance really is affected by the amount of alveolar bone where the root is embedded and the length of the root within the alveolar bone. So this is really, these are important factors that affect the center of resistance. So it's not a fixed point, it differ according to the changes surrounding the tooth. So if we have healthy periodontium, healthy alveolar bone level, healthy and normal root length, then usually the center of resistance is halfway down the root, halfway down the root. If we're talking about multi-rooted tooth, then usually it's about 1 to 2 millimeters below the bifurcation area. The forcation area, below the forcation area. Now, for certain circumstances, when you have a resorption of the bone, alveolar bone, what happens to the center of resistance is that it will move further apically, further downward, okay? If the root is starting to resorb, then the center of resistance will start to move more occlusally, okay? So the center of resistance is really, its position is affected by the amount of alveolar bone and the root length of the tooth as it changes. So this is a multi-rooted tooth. This is the center of resistance. If you apply a force that can go directly through this center of resistance, then you expect a bodily movement. Bodily movement is the movement of the root and the crown, and all points on the tooth in the same direction at the same rate um, as an effect of this force. But if the force is away from the center of resistance, then you expect this type of tooth movement. We usually call it tipping. Right. Now, center of rotation is the point around which a body appears to rotate. Now, please just focus here. When we say rotation, okay, these are mechanical concepts. So don't be confused when we say rotation, tipping now, and then later on when we talk about orthodontic tipping tooth movement and orthodontic rotational tooth movement. Okay, they're a little bit different. So here, when we talk about rotation, it's more a mechanical or general concept. So center of rotation is the point around which a body appears to rotate. And of course, it's different. It depends on the type of tooth movement. Now, we have 5 different scenarios. The center of rotation could be exactly at the center of resistance, so both of them are coincident, if we have pure tipping movement, pure tipping of the tooth, okay? Now, it is positioned more apically than the center of resistance. In this case, we have uncontrolled tipping. Uncontrolled tipping where the root can actually move and cause some problems. This uncontrolled tipping. Now, if the center of rotation is at the apex, exactly at the apex, then we will have controlled tipping of the crown. If the center of rotation is at the incisal edge, exactly the opposite, at the incisal edge, what happens is that we will have rotation of the root. When the root is moving within the bone, we usually use the word torquing. We usually use the word, in orthodontics, we use the word root torque. Okay, if the root is moving vacuolingually. Mesodistally, maybe we can say tipping of the root. The center of rotation is at infinity if the tooth is moving bodily. If we have bodily movement, then there will be no location for the center of rotation. It's at the infinity. Okay, so these are the 5 different scenarios to locate the center of rotation. Now we need to talk about 2 concepts here. The moment. And the moment is a rotational effect that is produced when a force is applied away from the center of resistance. And we can calculate it by having the force magnitude multiplied by the distance from the center of resistance. So this is an example. So you have the center of resistance. The green dot here is the center of rotation. So we have a force that is applied. This is the red arrow. It represents the force applied through this bracket. So if you apply a force of 100 grams that is located away from the center of resistance of about 10 millimeters, then the amount of moment that is produced is 100 multiplied by 10. So it's 1,000. Okay. If the force is applied exactly through the center of resistance, that means the 100 is multiplied by 0 because the distance away from the center of resistance is 0. So if the force is applied through the center of resistance, there will be no moment. Moment is 0. I cannot produce a moment. The further you are away from the center of resistance, the more the increased magnitude of the moment. On the other hand, if you apply 2 forces that are equal in magnitude and opposite in direction that are not working on the same line, then you will produce what we call a couple. A couple. It will not produce bodily movement. It will produce purely rotational movement. Purely rotational movement. Again, the word rotation, the word tipping, we are talking about general mechanical concepts. Now, if we have a couple that is combined with a moment with another additional force, usually we can produce a bodily movement. But a moment alone, a couple alone cannot produce a bodily movement. Usually they produce rotational effect on the tooth. So this is a fixed appliance where we have brackets and we have a wire system here. So as you can see, if the wire is round and it has two contact points on the bracket, these are 4 bracket wings. So we have a slot, 4 bracket wings, all on a base. Okay. So if you insert the wire like here, then usually you will have some areas of the bracket that comes in contact with the wire. This is where the force is applied. So if we look here, this is an example where you have a force acting on this wing here and another one acting on this wing here. So these two forces from the same wire will be equal, opposite in direction, and they are not working on the same line. So these is what we call a couple. And they will produce rotational effect of the crown in this direction. This is looking at the bracket cross section. So if you cut the bracket like this and you look at the wire, and this is not a round wire, this is a rectangular wire. If you look at it, it's active inside the bracket slot and it has 2 points of contact here and here. These 2 points of contact will produce 2 forces equal in magnitude, opposite in direction, but not acting on the same line. So this will produce a couple. Okay. The same here in another dimension. So here we're looking at the frontal view, cross-sectional view, and this is the occlusal view. Again, the force will be acting on 2 points. Okay, so pushing to the inside, pushing to the outside, and we will have 2 equal forces acting on the tooth, not on the same line, equal in magnitude, opposite in direction. So this is another example of a couple. If we combined the couple with a moment, then we can produce a bodily movement. So the force, this big force acting here will produce a moment. These forces within the bracket system will produce a couple. So the rotational effect of the couple will be counteracted by the rotational effect of the moment, and we will end up having bodily movement. Okay. Tipping. Tipping is a moment applied by active components of removable appliances or round wire with fixed appliances. So if I want to produce a tipping movement, then I need a single point of force being applied to the tooth. This is possible by using removable appliances. And as you remember, removable appliances have different active components. And here we're talking about springs, for example, Z-spring, the little finger spring, etc. So we have a single force application using removable appliance, or we can use fixed appliance, but here we're talking about round wire. Okay, these 2 scenarios can cause tipping of the tooth. If I want a bodily movement, as we said, we need a couple and a moment. We need 3 forces in order to produce this. And this can only be achieved with fixed appliances. And, more specifically, fixed appliances with rectangular wires. This is the combination. So we have a moment, we have a couple, and then we end up with bodily movement. Now, the reason why we're talking about the couple and the moment, because in clinical practice, for me to produce a bodily movement of the tooth, I need to apply a force that goes directly through the center of resistance, which is almost impossible, or let's say very difficult. The setup of orthodontic appliance to produce a force that goes directly through the center of resistance is very difficult. And in order to overcome this problem, this is where we use the 3 forces that we just explained. Okay, so a force that is applied to the tooth, usually a moment, and some rotation is always produced. It's inevitable. It's always produced. Right. So here, when we apply a single force, we will produce away from the center of resistance, we will produce a moment and rotational effect, ending up with tipping. And if we have a bracket and a rectangular wire, then I will produce a couple. And then if we apply a moment at the same time, then the rotational effect of the moment will be counteracted by the rotational effect of the couple, and I will end up having a bodily movement. Okay, and this is the concept of using fixed appliances to produce bodily movement. Now we will come to the effect of force distribution. Okay, now the optimum force levels for orthodontic tooth movement should be just high enough to stimulate cellular activity without completely occluding blood vessels within the periodontal ligament. We said that if we start to have occlusion of the blood vessels, that means we will start to have heavy forces that result in hyalinization, cell death, and delayed tooth movement, and undermining resorption, indirect tooth movement, right? Remember all these from the first part of this talk. So as you can see, this diagram is important, and it gives you the relationship between the force applied to the tooth and the amount of tooth movement. So as long as the force is below the threshold of the periodontal cellular activity to stabilize the tooth position, as long as it's low, we will have no tooth movement. Once we reach the threshold above which we will start to have a little bit of tooth movement, then this is we will start to have the efficiency of tooth movement starting from this point here. So this part here, we have no tooth movement. This is when we have a force that is applied that can overcome the stabilization effect of the healthy periodontium, okay? As we increase the force, we can increase the amount of tooth movement. So this is healthy light force. As we increase the force, we will still have good amount of tooth movement until we reach this plateau. So just before this maximum plateau, this is what we call the optimal force. Optimal force is high enough to produce healthy cellular activity without causing undermining resorption, without causing occlusion of the blood vessels. As you increase the force beyond the optimal force, you will not have more tooth movement. On the contrary, you can reach to a point where you have actually delayed tooth movement because you will have consequences of heavy forces that might include the pain, discomfort, reduced patient compliance, as we said, cell death, hyalinization, undermining resorption, increased risk of tooth resorption, etc., etc. So this is the relationship between the amount of force and tooth movement. Now, the biological effect of a force that is applied to the tooth, its effect is really dependent on three important factors: the force magnitude, the force per unit area, which we call the pressure, and the force duration. Okay? Now, the force per unit area for a tooth, when we apply the force, usually it is distributed along the root surface area that is embedded in bone. So our pressure, our produced pressure is dependent on the root surface area, which means that it depends on which tooth we're moving. Is it a single rooted tooth or is it a multi-rooted tooth? Because number of roots and root surface area will affect the amount of pressure at the end after you apply a force. Okay, so the same force applied to an incisor will produce more pressure than a force that is applied to a molar with a multi-rooted tooth, because a molar will have a higher root surface area, so the same force will be distributed along a bigger surface area. So we will have less pressure at the end compared to an incisor. It also, the force per unit area will be affected by the type of tooth movement. And how is that being explained? By looking at the loading diagram of the periodontium. And here we're going to talk about the type of tooth movement. So we have 6 different types of tooth movement. So these are the terminologies that are related to orthodontic tooth movement. Okay, so we have tipping, rotation, extrusion. These 3 will have almost the same range of force necessary. And we always have a range because we are considering the single rooted tooth and we are considering the multi-rooted teeth. So we need less force for smaller teeth and bigger force for multi-rooted teeth in order to reach the same pressure. Okay, so in order to reach the same pressure and so the same effect in terms of tooth movement. So tipping, rotation, extrusion. Intrusion will require the minimal amount of force. And then the maximum amount of force is needed if I'm trying to go for a bodily movement, 70 to 120. And then root uprighting or root torquing will require the second biggest amount of force, 50 to 100. Okay, so as you can see here, this is tipping, and it is uncontrolled because the center of rotation is apical to the center of resistance. This is controlled tipping because the center of rotation is exactly at the apex. This is to show you the intrusion. Here we have bodily movement, and this is showing you the torquing of the root. Well, the center of rotation is actually exactly at the incisal edge. And here to show you the extrusion effect in terms of tooth movement. And the rotation is not shown here, but rotation is to move the tooth along around the long axis, around the long axis. This is the orthodontic rotational movement. Okay, so force magnitude, optimal force magnitude will differ according to the type of tooth movement. Tipping movement is the simplest form of orthodontic tooth movement, and as we said, it requires 35 to 60 grams to be produced efficiently. And it is produced by applying a single force contact to the tooth in order to end up with a moment. So the moment applied to the tooth will produce tipping movement. And as you can see here, the periodontal ligament will be compressed and stressed near the root apex on the same side. So this is the root apex on the same side of the force will be stressed, and at the alveolar crest on the opposite side. So this is the alveolar crest at the opposite side of the force. So the areas that will be compressed and stressed will be the root apex on the same side of the force, and the alveolar crest at the opposite side of the force being applied. Okay, so this is another example of a single force applied to the crown, and what happens is that we will have pressure area of the apex on the same side and pressure area of the alveolar crest on the opposite side. If we look at the loading diagram, so this side here, this palatal side will be loaded, half of it will be loaded or stressed, and the buccal side, again, half of it will be loaded. So half of the amount of periodontal ligament during tipping movement will be loaded. So this is the lower right canine. If we apply, I know that during movement we moved lots of teeth in lots of directions, but if we just focus on this canine, we will see that we applied a force on the crown and it tipped, the crown tipped buccally. So here to show you the controlled tipping, where we have the center of rotation exactly at the apex, and we have controlled crown tipping. As the center of rotation goes away from the apex, in between the center of resistance and the apex, we will have uncontrolled tipping because the root will start to move, and sometimes this is could be excessive, causing problems. So if the center of rotation is here, then we can be the tipping of the crown could be seen clinically, and it is controlled. We know exactly where the crown is going. Bodily movement. Bodily movement is to move all points on the root and the crown, as we said, in the same direction, same rate. Usually the amount of force needed to produce this type of tooth movement is 70 to 120 grams. And to produce such bodily movement, in theory, we need 3 forces, 2 that produce a couple and 1 that produce the moment. So we need 2 simultaneous force systems used in orthodontics. Now, if we look at the loading diagram, then palatally, the whole periodontium will be loaded. So we will have a full loaded diagram, periodontal diagram. The other side will have a full tension or stretching of the periodontium. Now, if we look in theory, this is exactly what happens. But in real life, what happens is that moving from position A to position B, really in between we have small detailed cascade of events that includes multiple tipping, multiple uprighting. So if we looked at a tooth that is moving bodily, for example, this lower molar, as it moves from here, position A, to here, position B, we say, oh, this is a bodily movement. But if we look at the tiny details of the cascade events, how the molar reached here, it's not it's impossible to have a pure bodily movement. In between, you will have a little bit of tip upright until the tooth actually reaches this new position. So this is to show you a force. If the force is applied directly through the center of rotation, center of resistance, of course, you will end up having bodily movement. And the center of rotation will be at the infinity. But this is not possible, or let's say very difficult in an orthodontic system. And instead, what we do is to apply a couple and a moment in order to produce such bodily movement. Rotational movement is the movement of the tooth around its long axis. Okay, so for example, this 7 here is, to start off with, is rotated mesiolabially, okay, or mesiobuccally. I want to use a force in order to rotate it back mesiopalatally to be well aligned within the arch form, okay? So what type of tooth movement I need? I need mesiopalatal rotation of this second molar in order to become, to align this tooth within the line of the arch. So in theory, if you have pure rotation, then the loading diagram is full loading diagram in all around the root. So we have a huge amount of loading areas. So we need, in theory, we need the largest force, the largest amount of force. But this is not true, again, because what happens is that we will have a little bit of tipping. At a certain point, we will have more areas loaded than the others, and we will end up having a cascade of events where we have multiple tipping in order to reach the end of the rotation. So yeah, so although in theory we need large force, but the um, range of force for the rotation is exactly the same as tipping movement. It's 35 to 60 grams because at the end it's a cascade of or multiple rotational tipping movements. So if we focus on the upper left lateral incisor, we could see that this tooth is not well aligned and it is rotated distolabially. And I want to use an appliance in order to align it. So what happened here is a rotational movement where we move the upper left lateral incisor distopalatally. So this is a distopalatal rotation. So the rotation is the movement of the tooth around the long axis. Okay, so this is from the orthodontic point of view. Right, extrusion. Now, again, in theory, if you think about it, I want to pull the tooth away from the socket. So if I have a pure, perfect extrusion, then there will be no loading diagram at all. The loading diagram of the periodontium will be 0 because I'm pulling the tooth away from the socket at all points, okay? And it will, there will be no pressure areas at all. But actually what happens in real life is that we will have unavoidable tipping. And again, extrusion is the same as rotation, as same as tipping. We will end up needing 35 to 60 grams to produce such tooth movement. So this is a canine that was extruded, as you can see, and it requires this range of tooth movement. Intrusion, if you go for perfect, beautiful intrusion along the long axis of the tooth, then the only area that will be stressed and compressed is the root apex, okay? And so this is small area will require gentle force in order to produce this tooth movement with minimal consequences of root resorption, pain, and other problems. So we will need 100 to 20 grams. So if this tooth movement was actually applied, it's a bit dangerous because the area that is pressed is very, very small. And pressure produced from this force will be huge because the root surface area being pressed is very small. But in real life, this is a pure intrusion again is not possible. We will always end up having different areas being pressured along the way, and we will have unavoidable tipping. Okay, so the range of tooth movement necessary for intrusion is the lowest among the 6 different types of orthodontic tooth movement. It requires 10 to 20 grams. Always be gentle when you go for intrusion. So these are the incisors. Upper incisor, we wanted to intrude them a little bit in order to give to clear the way for a prosthetic replacement of the missing lateral incisor. Okay, so this is an intrusion force. We go gentle and we use very minimal forces. Root uprighting. Okay, when the root is moving within the bone, buccolingually, we call it torquing. So we can torque the root labially, we can torque the root lingually or palatally. Okay, and usually we can produce this using a couple with a fixed appliance and a rectangular wire. So this is a beautiful torquing here where we have the center of rotation exactly at the incisal edge. So the movement of the crown is minimal and most of the movement is within the bone, within the root. And this is why most of the loading area will be larger area of the periodontium along the root, so we will need 50 to 100 grams to be able to produce such tooth movement. So again, a force is applied. Of course, in theory, this is where the force is applied, but in practical, in practice, what happens is that we apply a couple, and it will end up having a rotational effect in this area here, and we will end up having root movement. So this is the lateral incisor. The crown is almost in the correct position, and the root is not, obviously, is too palatally, it's positioned too palatally. So we need to torque the root labially. So we can produce this type of tooth movement in order to correct its position. So we call it root torquing. So these are the 6 main types of orthodontic movement and the range of forces necessary to produce them efficiently, let's say, with optimal tooth amount of force. Now let's talk about the effects of force duration. Force duration, when we say sustained force, it means a force that is present for a considerable percentage of time, okay? And we're talking about hours, not minutes. We're talking about hours. Now, for the second messenger's level to reach the threshold in order to stimulate cellular differentiation after you apply the force, you will need a sustained force for at least 4 hours. After 4 hours, you will start to have some cellular activities and you will start to have second messengers elevating their level in order to start the cascade of events that are necessary to have a tooth movement. Now, in humans, the threshold of force duration is 6 hours. 6 hours, okay? The longer duration, the more effective tooth movement. Okay, what is the maximum? Of course, 24 hours. There is no more time than this. So it's like you're wearing it full time. Full time, that means 24 hours a day. So this is a diagram that shows you the relationship between the duration, hours per day, and of course, as you can see, 6, 12, 18, 24, 24. That's it. We cannot go anything beyond this. You cannot wear an appliance more than 24, of course. And here the other line is representing the tooth movement efficiency. Less than 6 hours, there is zero efficient tooth movement. Nothing will happen. So if you're having a removable appliance and you're putting it on, off, every time it hurts you take it out and then in and out, then you will have no tooth movement. The appliance will be inefficient. Okay, you need the appliance to stay at least 6 hours, continuous 6 hours, before you start to have a little bit of effect, before you start to have some effect. So this is the threshold, 6 hours. As you increase the time, you increase efficiency. If you wear 24 hours, you will have a perfect efficiency, 100% efficient tooth movement. So a removable appliance is going to be taken several times a day from the mouth for cleaning. Maybe the patient will forget it outside his mouth. Maybe there's pain or discomfort. The patient will take it out. So we will have less efficient. We will not have a proper sustained force compared with the fixed appliance that is in theory is there all the time, 24 hours. So it's more efficient in terms of tooth movement. Now, since we're talking about the duration of force, how is that related to the force decay? Now, the ideal spring that does not exist in orthodontics is a spring that would apply a consistent force magnitude to the tooth. Consistent force magnitude, which is not possible, because what happens is that the moment the force is applied to the tooth will start to move within the periodontal ligament space, and then we will have the second messenger level threshold, and then we will start to have a cascade of events that will end up having root bone resorption and tooth movement, right? So the force will not stay the same. It will reduce in amount because the tooth is moving away from this force. So this is what we call force decay, is the decline in force magnitude as a result of tooth movement. It is called force decay. So a perfect spring does not exist because as you move tooth, then the force will reduce in amount. Now, based on this fact, we can classify the orthodontic force duration based on the rate of decay as follows. We can have a continuous force that will maintain a considerable amount of its magnitude a long time. Interrupted is a force that will reach to zero between visits to the orthodontist. Intermittent is a force that is on off. It will decline and decay, but it will be zero amount several times a day. So this is what we call intermittent. Okay, so the green dashed line here represent the ideal spring, where we have a certain amount of force. It should be the same at all times. The small green arrow here represent the visit to the orthodontist. So the amount of force in theory for the ideal spring should be the same between visits, exactly the same. No need for activation, it's the same, right? But in real life, the continuous force, so this is the amount of force that is applied to the tooth between visits, which is about 4 to 6 weeks, sometimes 8 weeks. What happens to the force is that it declines. It reduces in amount until it never reaches zero. The continuous force never reaches zero between visits. So it declines, and then the next visit, the orthodontist will reactivate the appliance, and then between visits, it will decline, and then again, it will be activated and decline. So this is the normal pattern of force for a fixed orthodontic appliance. The interrupted force is an appliance that will start with the optimal force, and then between visits, it will decline, but it will reach zero. Why? Well, maybe because the patient missed multiple appointments and he came after the force actually decayed to zero. Or maybe the orthodontist activated the appliance very little so that in between visits, actually the force did reach zero. Okay, so again, it's still a fixed appliance. It is a fixed, this is showing a fixed appliance, fixed orthodontic appliance, but between visits, it reaches zero amount of force. This is what we call the interrupted type of force, interrupted. This diagram here shows you something else. It shows you that we started with this optimal force, and then it dropped to zero. What happened? Oh, the patient is removing his appliance for cleaning, and then he had maybe an hour of rest or so, and then he went back to wearing the appliance again, and then we have decline of force, and then we have a zero amount of force, and then decline of, etc. So it's an on-off. So this is representing a removable appliance type of force decay, and it is called intermittent, on-off, on-off. So the force will reach zero multiple times before the visit of the orthodontist, before the visit and the reactivation of the appliance. Okay, so the appliance is removed, the appliance is inserted, and so on and so forth. So if we remember, when we talked about the growth modification about the face mask. So the face mask actually represent this type of force decay. Okay, and it is called the intermittent force. Anything removable, like the medium opening activator, again, it is represented with this diagram, the intermittent force. The appliance here is called quad helix. Quad helix is used for expansion, and it is cemented to the molars, so it is fixed. So it's supposed to follow the continuous amount of force, unless the patient missed lots of appointments or the activation was too little, then it might reach to this level here. So ideally, it represents continuous force. Okay, ideally, if we have no problems with the patient with good compliance, then it should represent the continuous force diagram here. Headgear is removable, so this is the diagram that represented. The fixed appliance represented with this diagram, okay? Now, what's the effect of drugs on orthodontic tooth movement, as if you remember, when we have a pressure on the tooth, we will have disturbance of the cellular membranes, cell membrane of the different cells found within this area. And what happens is that the cell membrane will be, the arachidonic acid will be disturbed, and it will produce leukotrienes, prostaglandins, and thromboxane A2. Okay, and these are necessary to start the tooth movement. So if these were inhibited, then we expect a delay and inhibition of tooth movement. Prostaglandin inhibitors, like the non-steroidal anti-inflammatory drugs and the corticosteroids that are used as painkillers, might inhibit tooth movement because of this theory here, the pressure tension theory. And so, on the other hand, if you apply prostaglandin locally, if you inject prostaglandin locally, in theory, this should increase rate of tooth movement. But actually, this is a painful process, and the efficiency was not proved scientifically, and it's not used. This is not commonly used. Relaxin was a pregnancy hormone that was identified in the 1980s, and it is a hormone that caused the breakdown of collagen fibers. And since the tooth movement should include periodontal turnover, they thought that the injection of such a hormone locally within the periodontal ligament where we want to move teeth might increase tooth movement. But the positive effect of it, according to the studies, was not consistent. So we don't use this. Bisphosphonate is a drug given to patients with osteoporosis, and it inhibits tooth movement because it inhibits bone turnover. So patients with osteoporosis, it's important to take proper medical history and record the medications for such cases. And this brings us to the last topic here, the many trials that were made in order to enhance tooth movement orthodontically, enhance tooth movement and accelerate tooth movement orthodontically. And there are different ways to do it, okay? This has been a hot topic lately, and still is a hot topic, because everyone wants to attract patients to their clinics by claiming that they move teeth more quickly and they can finish the treatment faster, shorter treatment duration, and they can fill their clinic with more patients based on this theory. So the first technique is local injury, corticotomy or modified corticotomy or microperforation. Also the use of vibration, tissue penetrating light, and therapeutic ultrasound. These are the different techniques. Corticotomy was introduced by Cole in the mid-20th century, and basically you raise a flap. You actually raise a flap buccally and lingually, okay? And then you perform vertical cuts in between the roots of the teeth that you want to move, and it should produce acceleration of tooth movement for about 2 to 4 months, which is the time that we need for the initial stage of alignment, okay? So it was found that this is efficient in accelerating the alignment stage only, but the overall treatment time, there was no significant difference between this technique and patients who had no corticotomy. So the disadvantage of this technique, of course, financial burden on the patient, treatment burden also for the patient, and for the clinician, because you will need a surgeon. Morbidity, traumatic, it's an excessive traumatic procedure. possible loss of alveolar bone, possible increased risk of root resorption, etc. So here comes the terminology accelerated osteogenic orthodontics. Accelerated osteogenic orthodontics. Again, they are adding facial decortication and cover the bone with bovine or allograft bone. And again, there is no evidence of such benefit. These are aggressive procedures. And this is why this procedure was modified into a more gentle, less aggressive procedure, what we call Bezo-session. This was introduced by Debart in 2009. There was no flap necessary to be raised. Gingival incisions are made on the facial side. Vibrating piezoelectric knife is used for bone injury, and it's better than corticotomy because it's less aggressive. Randomized clinical trial found that the overall treatment time was shortened, but we need to be careful when we interpret the results of such a study, although it's a strong study, but the sample size was small. So we need to be careful when we talk about the results of this study. Microperforation was developed by a commercial company. And as you can see, you don't need to raise a flap or to go for periodontal surgery. The orthodontist can perform this. He doesn't need the surgeon or the periodontist. The idea is to have screws that are placed in and then they are removed. Or this small gun or machine that can go for a small penetration through the bone. There was no scientific evidence and no data that can support this technique. So this is an idea, but we don't have an evidence of its efficiency. Vibration, we talked about this when we talked about the piezoelectric current, if you remember, the piezoelectric theory during tooth movement. And we said that some scientists tried to overcome the problem of the piezoelectric current decay because it decays quickly after you apply the force. So to continue having this current to accelerate the movement, they started to think about vibration. And it delivers high frequency vibration of about 30 hertz. It is used 20 minutes per day. This machine is used 20 minutes per day. And in theory, as we said, it should stimulate cell differentiation and maturation and then quicker bone remodeling. These were further modified and introduced, especially with the use of clear aligners. And they use it 5 minutes a day only. Okay. Now, based on the clinical trials, the effectiveness is highly questionable. So if we compare of patients who use it and patients who don't use it, really there is no big clinically significant difference. They don't only use this, by the way, to increase the rate of tooth movement, but sometimes they use it to relieve pain, to reduce pain resulting from pressure on teeth and tooth movement. Tissue penetrating light, which is Violex, again, this is the trade name. It produces 800 to 850 nanometer wavelength. This light will be infused, the energy of the light will be infused directly into bone tissue. And the evidence and the studies showed that it will not produce faster tooth movement and it will not reduce pain from orthodontic appliances. Therapeutic ultrasound SmileSonic Aevo. Again, this is a trade name, and it's a low-intensity therapeutic ultrasound that, in theory, should increase blood flow. And if you increase blood flow, that means you will increase periodontal and bone turnover, and you will enhance orthodontic tooth movement. Again, there is no convincing demonstration of effectiveness to accelerate tooth movement. There is no evidence. But these are you need to know the different trials and different ideas of accelerating tooth movement. So local injury, vibration, tissue penetrating light, and therapeutic ultrasound. So we covered here the basic mechanical concepts, the types of tooth movement, duration of force and decay of force, and drugs' effect on tooth movement and acceleration of tooth movement. I hope that this clarified this topic, and thank you for listening.